Pleasure to introduce our next symposium. I will be co-moderating with Dr. Dobbs. We put together a symposium looking at the latest and greatest in terms of controversies, topics, as far as cervical spine technology, and questions that we often get with these topics. We put together a great slew of speakers and topics. I'd like to point out that there is one additional talk in this session from Samuel Cho, looking at different materials for the use of interbody cages as well. Final speaker for the session, Dr. Samuel Cho, will talk to us about interbody cage materials with titanium and bone.
Thank you for the invitation. So let's talk about titanium. These are my disclosures. So as we all know, ACDF continues to be the daily workhorse for all of us cervical spine surgeons. This is one of the more recent national database studies looking at 44,000 single-level ACDFs, and during the same period, there was just over 1,000 artificial discs. So that means that 98% of single-level disease in the cervical spine is done with a fusion, statistically speaking, compared to artificial discs. As we know, the ideal bone graft substitute has the following properties. It has to be osteoconductive, osteoinductive, and osteogenic. And there had been significant improvements in evolution of bone grafting. All the way to the left is the traditional iliac crest autograft harvest. In an ACDF case, this is essentially two separate surgeries, right? You have to make another skin incision, dig down the bone, take an osteotome, and bite out a piece of autograft. It has surgical site of morbidity, limited supply, sizing, and shaping, unless you're a master surgeon, can be quite challenging. Next is the structural allograft. Depending on the cadaver from which you derive these grafts, there are biomechanical variabilities. We all have seen graft resorption with time, and the sizes are not optimal a lot of times, and there's the rare risk of disease transmission. And all the way over to the right side is some of the biomaterials that we are talking about today, and then the issues are cost and biological activities. Why titanium? Let's look at the periodic table from high school chemistry. It's one of the transition metals with the atomic number 22. It was first discovered by chemist William Gregor from Great Britain in 1791. And the name titanium was given by a Prussian chemist after the Titans of Greek mythology. The reason as to why we're using titanium are because of the properties that are favorable in the spine. First, it's biocompatible, it's bioinert. It doesn't interact with any of the human tissue. It's highly corrosion resistant. It readily forms an oxide layer, and unlike iron, it doesn't rust. Thirdly, it has the highest strength to density ratio. It's the strong metal with very light properties. So you can make airplanes out of it, you can make glass frames out of it, and also you can make ACDF cages out of it. This is a often argued comparison between PEEK and titanium, right? So we know that PEEK is radiolucent, whereas titanium, you can't really see anything, especially when you're assessing fusion. PEEK has a similar modulus of elasticity compared to cancellous bone. Titanium, obviously, being a metal, is highly stiff. And the only thing is biology. Titanium is more osteogenic than hydrophobic PEEK. So PEEK wins in this relatively simple argument. But let's break it down and look at the imaging first. I would argue that not all titanium cages are created equal, right? So this cage, there's mesh in the body of the cage. You can't really see anything. Same thing with this model. But if you look at certain models, there's a hollow hole through which you can actually see bone, right, potentially. But according to Dr. Ru over here, that's not the correct way of assessing bone effusion. You actually have to look at the lateral x-rays, magnified 1.5 times, obtain flexion extension x-rays, and measure inner spinous process distance. That's how you assess bone effusion. So you don't even have to look into the disc space. So next time you see a titanium cage after ACDF, what you want to do is magnify the image 1.5 times, make it bigger, obtain flexion extension x-rays, and simply measure inner spinous distances. And if it is more than one, you can safely assume that it is not fused. What about metal artifact, right? So, a lot of us get MRIs after fusion for adjacent level problems, et cetera. Well, if you actually look at the literature, this is a prospective compared cohort study looking at 20 titanium artificial discs compared to 20 cobalt chrome discs. Obviously, cobalt chrome has a lot more metal artifact, but titanium actually is okay. Here's a figure from that study illustrating that you can see the entire spinal canal. You can actually see the foramen quite well, adjacent level, no problem. Whereas with cobalt chrome, there are problems with post-imaging, procedural imaging. Secondarily, stiffness. The simple argument that people give is, look at this Young's modulus, right? So all the way to the left is the cortical bone, very low. Peak mimics that modulus. Titanium underlined and also titanium alloy are a lot stiffer and stronger. But when you look at two different things with the same Young's modulus, you can readily see the difference, right? I can bend this paperclip with my 2 fingers. Crowbar, no way. I bet you there's no one who can bend this. So design matters, and over the past couple of decades, there had been steady evolution of implant design changes, and since the 1910s, we've been adding pores, holes into the body of the cage. You can use mathematical formulas and equations to derive at optimal design of these cages, as you see in this study. And you can use all kinds of different manufacturing methods to poke holes into the cage, from completely opaque to 80% air. The latest iteration of technology that we've adopted as a spine community would be 3D printing, right? That started circa 2018. To give you some historical trivia, 3D printing actually was first described by Murray Leinster. That's the pen name for Mr. William Jenkins in a science short story called Things Pass By. It says that the machine makes drawings in the air, following drawings it scans with photocells, but plastic comes out of the end of the drawing arm and hardens as it comes, following the drawings only. So it's describing 3D printing science fiction. Couple decades later, in 1969, there was the first patent, so science fiction became reality. And ever since then, we've been using in cervical spine surgery. This is a review out of Emory, looking at 120 titanium cages, comparing to 115 structural allograft with minimum 1-year follow-up. Using the dynamic pseudoarthrosis method, they found that the fusion rates were very similar between the two groups. However, titanium actually had the advantage of lessening subsidence throughout the study time period. So, in biology, I win in terms compared to peak, but let's look into it a little bit more. This is an old study from the mid-1990s, where they actually started roughening the surface of the titanium and found that roughened surfaces support extensive bone growth directly onto the implant, and they concluded that this method may provide an excellent surface for bone implant integration. So you can, on top of that, you can actually start adding stuff on the surface of the titanium. You can add to make it more osteo and angiogenic. So various coating manufacturing methods that I don't know a whole lot about, but described in the literature. You can plasma spray, grit blast, acid etch, and you can add calcium hydroxyapatite. I think all of us have used hydroxyapatite-coated pedicle screws, for example, So you can do all kinds of things to make sure that titanium sticks to bone. Future directions. So I've been thinking a lot. So when I learned how to do ACDF from Dan over here, he threw me a piece of bone and said, like, Sam, what does that look like? Square? All right, so we're gonna make that disc space just like the bone here. So I spent many, many hours shaving away at the anterior lip, making the uncovertebral joint flat and whatnot. But I've been thinking, the coat that I'm wearing right now is actually tailor-made to perfectly fit my body. But we are shaving the patient's bone to fit a piece of metal. Is that really the right way of doing things? So in the literature, there are actually examples of patient-specific implants that you can actually make using 3D printing. So this is an N of 6 published in 2018 looking at corpectomy polymer cages. There's actually a company not too far away from here who's making patient-specific titanium cages to address adult spinal deformity. So we went to our lab and said, if you scan the cervical spine, you can use various techniques in AI and machine learning and automatically segment out the bone, the disc space. And you can actually make an implant that's specifically designed for you at that specific level, right? So you maximize surface. You don't have to violate any of the uncovertebral joints where the robust bone is. Coupled with the morphology, you can actually do range of motion so that you don't have to over-distract, under-distract, or cause abnormal motion of even the facet joints. And you can convert the artificial cage into a simple cage or a disc to a cage and look at it in various angles and fit it perfectly so that you maximize the given space for the benefit of the patient. So over the past few decades, there had been continuous improvements in implant technology, and I think in the era of big data, AI, we can actually provide personalized treatment for each of the patients that we see in our ORs today. Thank you.
Right, Dr. Cho, with your advances in interbody devices, the technology is fascinating, but one of the things that was brought up by yourself and others is that with the available studies, it's hard to show a difference in fusion rates. And I'm getting a lot of pushback from my institution on the cost of these things. And as you go more and more to patient-specific and metal and expandable and 3D printed, you're seeing 3, 4, 5 times the cost for the interbody. So I wondered if you could comment on the value on that. Do you think there really is value in these new technologies, or have we reached this point of diminishing returns where you're spending more and more and more without much benefit?
Yeah, I think, obviously with the introduction of the newer technology, initially it's going to be more expensive, right? So for obvious reasons, the first electric car that were on the market were sports cars that only the super rich could afford. But, as we have seen on multiple occasions throughout history with, frequent iterations, things scale up and become cheaper. The benefit of computer technology is that these things potentially continue to learn and become better over time, and it's scalable. That's the benefit of software. You can just copy and paste 1,000 times without any added cost. So I think eventually, yes, the first introductions will be somewhat costly, but over time, once you scale, this actually can become cheaper. 3D printed cages, when the companies introduced them for the first time, they actually had a premium on it, but we actually all know that the cost of 3D printed cages are cheaper than traditional milled cages. So I'm hopeful that things will come down.
Dr. Heller.
Mike, is there time for one more question
Go ahead.
for the interbody technologies? Sam, you just made a comment about sort of the comparison between consumer electronics, downward pressure on price, that sort of thing. First, I want to challenge that assumption because there really is a floor effect on medical device pricing, right? No one is pricing an interbody device less than a piece of allograft. That's just sort of the entry-level cost for the industry. We know how difficult and expensive it is to process sterile human allograft. What are your thoughts about why we're still seeing those same prices on things that you could make, once a second out of a machine, spitting out a little piece of plastic? And same with titanium. Where do you really think we're going to see the value proposition go?
Yeah, so I'm an academic just like you, so I don't really think about cost and prices and such, but I think, as a member of the society, I do need to think about it. And I guess I would sort of push back a little bit and say that software really has changed how we live and behave, including in medicine. So with software, which is highly scalable, although there is going to be baseline cost of manufacturing these devices, we can actually make them eventually cheaper. And if we look at the example of pedicle screws when it first came out and the cost associated with it versus now, I think things can come down eventually. I don't know what the discussion is going to be between the manufacturing executives and hospital administrators who purchase these devices. That's way above my pay grade, but I'm hopeful that with the adoption of newer technology, things will scale up and come down. And ultimately, my hope is that there will be for sort of a measurable clinical benefit. And even if you look at the Emory study that John Rhee had published, subsidence was less with titanium, yes, but there was still subsidence of 2 millimeters or so. So maybe that has clinical meaning, maybe it doesn't, but hopefully we can actually improve our outcomes eventually with these new technologies.
Last week I did a 2-level ACDF. For the first time, United Healthcare called me and said I cannot use a cage. They wouldn't pay for 22853 and I had to use allograft. So I got on the phone with them, with United Health, and it's hard to make that argument because they say, well, why are you using that? And other than 22853, that's a challenging thing to answer. In addition, most people are putting some sort of allograft, whether it be BMP or Grafton or whatever, so there's also costs there. So I'm wondering, what are we going to say to the insurance company when I talk to United Health and they say you can't use your cage?
Yeah, I think that's why we exist, right? So it's on us to prove to the payers and other interested parties that the things that we utilize do have some clinical value. And right now, we cannot even agree on fusion definition and how to measure it. So I think we have a lot more homework on our hands.
Great. I want to thank all the speakers for a great session. Thank you.